Hi there, my name's Dr. Damian Roland. I'm one of the Paediatric Emergency Medicine consultants here at the Leicester Royal Infirmary, and I'm going to be talking briefly on our approach to sepsis in the Children's Emergency Department. This is a talk that's relevant to both medical and nursing staff who work in the Children's ED, but also the CAT team, the paediatric team who come down and work with us in the Children's ED as well. Sepsis is a challenging problem. The vast majority of children we see in the emergency department don't have sepsis and have simple, self-limiting viral disease for which they get better. The challenge is that for all the children that you think may have a virus, those who turn out to subsequently have sepsis, retrospectively, it can look quite obvious that sepsis was present at the time, even though it wasn't obvious when you were seeing the patient. And what we need to remember is that for every child that you're seeing, you need to consider the possibility that this is likely to be a viral disease, but also what are the features for that patient that make it potentially more likely that they have something that is more invasive. There are a number of myths around sepsis. While the inclusion criteria for having sepsis is fever, having a temperature, the height of the fever is essentially irrelevant. And just because you are 38.9 doesn't mean that you are any more or less likely than if you're 38.1 or 40.9. The parents may be hugely worried by the height of the temperature, but essentially you shouldn't be. Just because you've done blood tests doesn't rule in or out sepsis. A normal CRP and a normal white cell count don't determine the eventual outcome or disease process or disease longevity. And in fact, there is evidence that very early in a potential developing sepsis case that the bloods are likely to be normal because the body hasn't responded yet. And also, if you've seen a child with a negative blood culture that was perhaps taken the preceding day and that child has returned, that hasn't ruled out sepsis either. And especially important in winter is just because the child also has RSV or adenovirus or something else, that again doesn't rule out sepsis. So there's a lot of sepsis fiction out there, and it's important that you're aware of this. So what is sepsis? Well, this is a challenge in its own right. Sepsis is a hyperinflammatory response to a simple stimulus. For children, that mainly is infection, and that the body goes into overdrive, and that overdrive immune response produces leaky capillaries, which makes the child hypovolemic, and then you go into organ dysfunction and then failure, and an unfortunate outcome is sometimes death. But this is a random patient-centered response. So what I mean by that is that the same infection can be given to two different children of the same age and maybe the same genetic makeup, i.e. they're twins, and one of these children can get sepsis and the other doesn't. So it is really difficult to determine. And because there isn't one fixed test, our usual diagnosis is that you've got an infection, that you do have a response to that infection, and that you become either hypertensive or have organ dysfunction. You need a bit of time to work that out. They're not always present when that child first presents in the emergency department. And so a lot of our diagnoses are made on first appearance. And it's really important to differentiate between appearance and physiology. It is really, really unlikely that even if the physiology is markedly deranged, if your child is running around the department and is happy and smiling and waving at you, that they have sepsis. Now, the converse isn't true. that you can have normal physiology and look really unwell, and that can be sepsis. But actually, a lot of the children who appear unwell with normal physiology do respond relatively well to simple antipyretic treatment, and we're using that antipyretic treatment not because we're worried about the temperature itself, but what we want to see is how the child looks when they don't have a fever and what happens to their physiology when that fever is removed. Because if you have a child who, despite a dose of ibuprofen, is still looking not particularly bright, and that tachycardia is remaining, then that is something to be concerned about. The other thing to think about is, when do we shift from negative to positive results? I've already told you that negative CRPs and white cell counts don't tell us a lot, or positive don't really either, because there isn't one particular cutoff. A CRP of 30 versus a CRP of 60 versus a CRP of 90. It doesn't really help you unless you've been thinking before you do the test how you're going to react to that. So if you have a child who you think has a low probability of having sepsis, if you choose to do bloods, and you probably shouldn't be, because they've got a low probability, but you need to be thinking beforehand, okay, what level of CRP or white cell count am I going to action in this particular case? And so we need to be thinking about spectrum of disease. There are some children in which sepsis is highly likely, or it's definitely been confirmed, and if you don't treat that child's going to come to harm. And there are some children who it's obvious that sepsis isn't present, and no treatment will not result in harm. What we're really interested in the emergency department is the group in the middle, those with equipoise for the risk versus benefit. And they're the children that you need to be seeking senior advice for. And if you're worried about them, come and get someone else to have a look. We always have a registrar around 24 hours a day. Now, our process to looking at sepsis starts from the front door, where our VAC, visual assessment clinician, will work with the ward clerk in booking the patient in, and that child will be assigned a DPS. And if you're less than 3 months, your DPS will be 2. The DPS, the dynamic priority score, is at the start of our triage process within the emergency department. And those children who look unwell at this stage will also be given a DPS of 2, so that they will be prioritised for an initial nursing assessment. And this is a paper form that we don't use unless we have an electronic downtime in the emergency department. But essentially, the nursing assessment will ask a couple of trigger questions, which I'm now going to show via our electronic system. And what will happen is, when a patient books in and they are seeing a nurse in our assessment queue, the nurse will fill in a paediatric sepsis assessment. And at this stage, they will be asked for the sepsis screening page. So they will go to part 1, and they will either have a high suspicion of sepsis, or the child will be extremely high risk, by that they're less than 3 months old with a fever. They may have a high POP score, or their parent may be concerned, or they've got none of the above. If they have none of the above, that child will be immediately de-escalated. If the parent is concerned about sepsis, or that the child has a high POP score, that means that they've got a combination of a high heart rate, respiratory rate, temperature, or some other features, either of those will ask the nursing staff some further questions. And these are more of the screening parameters used in the NICE sepsis guidance, and it's whether that child has an ill-looking appearance, has low saturations, has a high heart rate for their age, has a changed behaviour, or maybe, in the case of a very small infant, a low temperature. Now, if they click on any of those particular parameters, which are stratified for age according to the program, then that will automatically generate a DPS2 and will put a sepsis task on the nerve center system. Now, if none of those features are present, then you will do none of the above, obviously, and that will de-escalate that particular patient. For any child who the nurse thinks has a high risk of sepsis, they look extremely unwell, or the child is less than 3 months, a DPS will be set to 1 and a sepsis task will automatically be generated, and it will highlight that sepsis treatment needs to commence. That will save on the system, and it will highlight in red what needs to happen next. Now, that system happens from a nursing point of view. The next step is really important for the doctors to then complete. If you move back into the system and you see that a patient has triggered for sepsis, then it is up to you to either start the sepsis treatment pathway. Please ignore this time since admission. That's just because this patient has been on the test system. In real life, that would be the time since that child has booked in to the emergency department. Now, at this point, you may decide that despite the fact that that child has triggered, that you would like to de-escalate, and then you either put the reason for your de-escalation or some written comments there, and then once that has been done, that you can de-escalate, and that will show on the computer system, and you will also have to close the sepsis task as well. Now, if you are going to treat as sepsis, you then have 2 pages to fill in. Again, it will warn you of the time passed. You put in where you think that the source of the infection is. There will be a reminder to provide oxygen if that is necessary, to take some blood tests via either IV or IO access, and make sure that you are completing the tests that are required as per our protocol, which will be full blood count, Euthanasia, coagulation, CRP, and a blood culture. A lumbar puncture if indicated, and you will notice for all of these boxes that there are possibilities of putting unable to obtain, to give antibiotics, and the time that they've been given, that is relevant. We can't automatically insert that time. You're going to have to put that in at the moment, and then the rationale if it was later than an hour. There's then another page of whether you've escalated to ICU or not, and then you can close that down. So that is essentially the sepsis process, and once you have completed that, it will show in the assessment box here. So when the child arrives, they will have a sepsis screen by the nursing staff, and if that child does trigger, there's then a medical responsibility to complete that sepsis assessment. Now, having decided a child may have sepsis and they need treatment, we have a number of sepsis boxes within the department, and in those sepsis boxes it tells you which antibiotics to use for which age range and which dose. If you're not sure where they are, just ask some of the nursing staff, and they're a really quick way of bringing the treatment to the patient and giving you some immediate guideline relevant advice. It's really important that we remember that the clock is ticking, and that there is still a time critical nature, that if you think a child does have sepsis, the evidence suggests that the earlier that we give antibiotics, the more likely it is that that child is going to have a good outcome. As I've explained, there is a clock on our sepsis assessment electronic proforma, but you also may want to have a quick look at your phone and start a timer going then if necessary. Ultimately, the large proportion of children that you see will have something that is minor and inconsequential, i.e. a viral disease. However, the consequences of missing something that is more severe can be life-changing for that particular child. So for all the children you see, take a bit of time, take a bit of care, listen to what the parents say, listen to their concerns, do a good and detailed examination, and if you're unsure, speak to a senior. Make sure for those patients who do come up as triggering positive for sepsis that you have either decided to de-escalate following discussion, or if you do decide that they need treatment, you fill in the sepsis assessment details. Thank you very much for listening. Please do speak to myself or our head of service, Rachel Roland, or speak to Jeremy Tong, who is the paediatric sepsis lead for the Trust. Thank you very much for your time.